Good evening, everybody. Welcome to this another session of Force and Echocardiography. Today we are going to deal with M mode and 2D Doppler measurements. I'm going to make it in two parts. Part 1 today will be M mode and 2D. And then subsequently we'll have Doppler part separately because that is what we felt for a number of times that we are lacking this particular subject. What? Please silent your mic. I'll request everybody to silent your mic. Then I'm Dr. Rakesh Gupta from Jorop Institute of Echo, Delhi. Couple of legends who are behind this particular program. And you must have met Mrs. Dina Dua during number of times on a telephonic calls. We have many accreditations like for Indian Academy of Echo, International Society of Cardiovascular Ultrasound Alabama, Delhi Medical Council. And whenever we do a hands-on training program, we take an appropriate permission from a CDMO Northwest districts. We can boast of saying that we are the only institute in India who has almost completed 25 years of existence with hands-on training programs. And we just celebrated this Silver Jubilee on 17th August 2025 in Delhi. Well, we started this program on 24th of September. And now today we are going to deal with the fourth session talking of MO, 2D and Doppler measurements. And that's two part of it. With this, let me switch over my gears. Well, the most important part of MO 2D examination is how we do really measure these structures. And we should have a uniformity of measurements. And we have derived this talk on basis of American Society of Echo chamber quantification guidelines. In 2D M mode echo, we need an evaluation of volumes, area, linear dimensions of LV cavity, estimation of contractile function of the heart, then what are the wall motion abnormalities, determination of LV mass, and monitoring the disease over a period of time. For this, we have a concept of leading edge to leading edge. What is this concept of leading edge to leading edge is, let me just show a particular diagram for this. If you look at this picture, this is 2 dimensions echocardiography. If I have to measure my LV size in this 2 dimensions echocardiography, I'll be measuring from trailing edge to leading edge. Now this is septum. This is the leading edge of the septum. This is the trailing edge of the septum. So I'm measuring from trailing edge to leading edge of the septum. And this is the posterior wall. This is the leading edge of the posterior wall. This is the leading edge of the trailing edge of the posterior wall. And if we do a cut of M mode across it, what we do is we measure from leading edge to leading edge. So if I'm measuring my LV cavity, I should be measuring my septum from this point to this point. Posterior wall, LV cavity from this point to this point, and the posterior wall from this point to this point. In concept to say that whenever we are measuring M mode, we are always measuring from leading edge to leading edge. And whenever we're doing a 2 dimensions measurement, we are doing from trailing edge to leading edge. A lot of confusion does happen when we're talking of all these things online. But when we show a live demonstration next week, I'll be able to make it clear. Now, same patient, this is the anterior aortic root. This is the posterior aortic root, correct? If this is anterior aortic root, for this root, this part is a leading edge. This part is a trailing edge of the root. So whatever the thickness of the heart is, the part which is closer to transducer is the leading edge. The part away from a transducer is a trailing edge. Similarly, if I'm doing an M mode echocardiography from this LA size, it is a leading edge is over here and a leading edge is over here in the posterior wall, LA free walls. And that's how we do measurements. Now start one by one in this leading edge to leading edge concept. How do we do it? We go to Planck's window. We make aorta horizontal as much possible. Then put a cut line across this aorta in the LA size. And whenever do a cut line, what we are measuring from leading edge of the LA aorta to leading edge of the posterior wall of the aorta. And if I'm measuring my LA is leading edge of the LA, leading edge to the LA free wall. And while cutting this, we are intersecting the aortic valve opening. So we are measuring the leading edge from the aortic valve opening from this point to this point. But the question is, the guideline says when we are measuring, we are not measuring from M mode, we are measuring from two dimensions echocardiography. What does it mean by? It means by if I'm measuring my LA, I'm measuring from this point to this point and LV from this point to this point. LA would be maximum in size during end systole. LV would be maximum in size during end diastole. So if I have to talk you in 2025, which one you should remember? I think the best part to remember is always remember two dimensions echocardiography. Go to end systole, maximum dimensions of LA from trailing edge to leading edge in Planck's view and trailing edge to leading edge in M mode during end diastole. Remember these two important things. Next comes the most important thing is this is what we have shown exactly what we need to look at in chamber quantification. This is the trailing edge of the interventricular septum. This is the leading edge of the posterior wall. So we are measuring from trailing edge to leading edge of LA. And this is a septal thickness from this point to this point and this point to this point. And this is the most important thing is when we are talking of the measurements, remember the most important thing is the LV size is 32 millimeter per meter body surface area, maximum. And LA size is 22 millimeter per meter body surface area. So this is I'm measuring during when? I'm measuring beginning of systole. This is beginning of diastole. So this is maximum 32 millimeter per meter body surface area. This is 22 millimeter per meter body surface area. That is the most important thing. And these dimensions has to be indexed. Indexed means you feed in a body surface area by putting height and weight. Machine will automatically give you index body surface area, and these values get decided by body surface areas. Now, this is what is the most important thing which you need to learn in your measurements. Second thing is you need to measure your LVOT diameters. How do you measure LVOT diameter? Hinge point of right cornicus, hinge point of left non-cornicus, and this is at the mid systole. This is what is the LVOT dimensions. Many books says many things to 3 to 5 millimeter inside, then you measure from this point to this point. But at your level, start measuring at the hinge point of right cornicus and a non-cornicus. So three values till now we have thought of LA, LV, aortic, LVOT diameter or aortic valve cusp opening diameter. Values 22 for LA, 32 millimeter per meter body surface area of LV, and the aorta is almost 15 to 26 millimeter in size. It's not index based as far as adults are concerned. Now, fourth most important thing comes from mitral valve area during perimetry. And once we are measuring mitral area perimetry, the most important thing is we have to measure the mitral valve area at what time? We have to measure the mitral valve area during the time when we are cutting at the tip of the mitral valve leaflets, not at the body, not at the base. So what do? You go from, look at the papillary muscles, go from papillary muscles back towards the aorta. And once you cut through these papillary muscles over here, then you get to the aortic mitral valve, then you find the maximum mitral valve area. So parasol short axis view, as we told you earlier, we start from parasol short axis view at mitral valve, go towards aorta, then we come down to mitral valve, then papillary muscles, and then apex. So we are doing reverse. We go to papillary muscles level at mid systole and coming back towards the mitral valve. Then we rest, not mid systole, coming back towards the mitral valve. We'll see the first area, which is known as mitral valve area by planimetry. Look at this. AML is completely seen over here. PML is completely seen over here. This is the lateral commissure. This is the medial commissure. And once you happen to see this, this absolutely looks like a fish mouth opening. And the mitral valve area is normally, when we take a mitral valve area, is about 2.5 to 4 centimeters square. Many times, many areas have changed. Many classifications have come up. But you have to remember one classification is severe mitral regurgitation, mitral stenosis is less than 1.5 centimeters square, very severe is less than 1 centimeter square, and progressive is more than 1.5 centimeters square. That I'm talking of mitral valve area by planimetry. Now, this classification has been challenged in 2024 by one of the paper published by Dr. Nat Pandians. But at your level, I'll still say less than 1 centimeter square, severely reduced. Less than 1.5 to 1 centimeter is, less than 1 centimeter square is very severely reduced. 1 to 1.5 centimeter is severely reduced, and more than 1.5 centimeters progressively mitral stenosis. Third important part is calculation of ejection fractions. Well, we have to calculate the ejection fraction in two views. One is a four-chamber view. We go to end diastole or beginning of systole, take the maximum dimensions, look at the mitral valve is just about to close down. So we start with the annulus, medial annulus, trace the endocardial border, come back to the lateral annulus, and the machine joins by itself. Then go to end systole and do the same thing. It'll give you and four-chamber ejection fractions. Now you go to two-chamber view and look at the same thing. It'll give you two-chamber ejection fractions, and it'll be a biplane modified Simpson's ejection fractions. Till now, guidelines have to change, but till now, we're talking of ejection fraction, male more than 52, females more than 54%. We did talk about wall motion abnormalities. I'll request you to all, if you remember the 16 segment model. I know many of you will not like my ideas. Is why I'm saying 16 segment model is because the machine still talks of 16 segment model or 19 segment model. What is that 16 segment model is? Mid basal septum, mid basal inferior wall, RCA, RCA, RCA. Mid basal posterior wall, mid basal lateral wall, circumflex, circumflex, circumflex. The rest all is LED. And next important thing is we have to measure the LA volumes. How do we measure the LA volumes? We take a four-chamber view or take a two-chamber view. Four-chamber view, maximum size of LA. We start with the medial annulus, trace the border across it, go to lateral annulus, and the shorter of these two dimensions. Same thing we do in two-chamber view, and we get short of these two dimensions, and that's will give you an LA volumes in absolute terms. Divide by body surface area, you will get indexed LA volume size. Normal is up to 34 ml per meter body surface area. Last but not the least, before I stop presentations over here, we measure LRV size. Maximum RV size would be when RV is about to go for systole. So end diastole or beginning of systole, we take a long axis view from apex to the mid of this annulus. First we join annulus, then we take a long axis view, then we take a short axis view. Once we have done RA measurement, RV measurement, we go on to measure my RA size now. And how do I measure my RA sizes? I'm going to measure my RA size when RS is bigger is size. So annulus to annulus hinge point, then middle of this line to the free wall and the short axis dimensions from septum to RA free walls. Last but not the least is we measure RVOT dimensions in two different views. One, we measure the RVOT dimensions, that is in parasternal short axis view at aorta. This is at the level of parasternal short axis view. This is proximal RVOT, and at the hinge point of pulmonic valve, this is known as distal RVOT dimensions. So this is proximal, this is distal. And the same thing what we measure in plaques window is this is proximal RVOT dimensions from this point to this point. And remember, whenever we measure LV or RV, LA or RA, they should be maximum in size before their contractions. In turn, to remember that LV and RV would be maximum in size at the end of end diastole. LA and RA would be maximum size at the end of end systole. And that's what is the most important thing which you need to remember this particular phenomena of these particular things when you are talking of LV-LA measurements. I'll stop over here, take your questions, because this is what you need to practice before I really go to the Doppler measurements, which are equally important. And this is what we have been facing number of times the problems with our workup when we see people who are not able to do a measurement, at least when the time they come for a hands-on training. So I'll stop over here and take your questions one by one. Just raise your hand and I request Ina ma'am to please record all the people present over here. In case I'm not able to give you some answer over here because I'm right now out of the country and I've lost my charger today. I'm at the verge of just closing down my computer. In case I'm not able to answer, I'll be able to answer in next class, which I'll announce very shortly. Dr. Anirban, go ahead and do it. Unmute yourself, Dr. Anirban, and you ask a question. Or I think we can keep the questions to next time. Meanwhile, just remember and we'll try to send you this recording as soon as possible. Pardon me for my quick presentations today because of lack of certain important issues and the things which are facing right now out of India where I'm not able to get my charger for my laptop. With this, viewers, let me stop my presentation and we'll take care of the questions very shortly at this moment. Thank you very much.